Good morning, everybody. It is Lisa Salberg, and today is October the 4th, 2024, and you are listening to Tales from the Heart, a podcast from the Hypertrophic Cardiomyopathy Association, and also a podcast in video form live on Facebook, LinkedIn, YouTube, and not the other place, Twitter, because they want to charge us, and I'm not going to pay Elon to do this live. So today I am joined by Dr. Michael Ayers. Michael, good morning.
Good morning. Thank you for having me. Always a pleasure.
Lovely to have you here with us. I think this is your second time on Tales from the Heart because you survived the last time we asked you to come on back and talk to us again. So thanks for that. So it is October, which means it is Sudden Cardiac Arrest Awareness Month. And for many in our community, this month may bring up some pretty harsh memories, and for some of us, maybe even a little PTSD for things that our families have been through. So we've kind of tagged this month with not only Sudden Cardiac Arrest Awareness Month, but emotional wellness, because we want to talk about the impact to our psyche these diagnoses may have. So from a personal point of view, I want to acknowledge that our family has dealt with sudden cardiac arrest more than once. My grandfather, Lawrence Sr., passed away in June of 1953, the age of 42, from sudden cardiac arrest. My uncle, Tom, lived in Stevensville, Montana. He succumbed to a cardiac arrest in August of 1990. And 5 years later, in June of 1995, my sister died of sudden cardiac arrest, associated with mismanagement and amiodarone overdose and drop of her potassium. So the rest of our family got these things called defibrillators to stop us from fibrillating and dying. And many of us are protected with this technology, and we're very grateful to all of those who participated in the development of device technology. And, there's names. Dr. Morosky is the originator of, the concept of an implantable pacemaker. Wilson Greatbatch, who was the inventor of the battery technology, making it small enough to fit inside of your body for pacemakers and then for defibrillators. These were two great pioneers in this technology. And while we acknowledge all of the families and family members we've lost, we thank them for the technology that has saved so many others. So a little history lesson there. Wilson Greatbatch, super cool dude, have his autograph in the other room. And Dr. Morosky, I was never able to meet him personally, but I've met members of his family and have given them your thanks through me for the technology that their family members created. So there's my dive down history. And Michael, sudden cardiac arrest in HCM. Challenging? Let's talk about it.
It is one of the more challenging and sometimes sticky things that we do on a day-to-day basis as HCM providers. I sort of start by saying, this is a personal decision. I'm going to help you the best that I can, but ultimately this is going to come down to what you want to do in this instance. I usually couch it as, we want to assess what we think your risk of dying suddenly is. And if it exceeds what we think the risk of implanting the defibrillator is, we're going to offer you a defibrillator. Now, I say offer, not hold you down and make you have. And I frequently tell stories like, based on your risk profile, my sister would ask 10,000 questions, probably get a defibrillator. My mom wouldn't have asked any questions and would get a defibrillator. And my brother would say, okay, sounds like I'm good to see you in 2 years then, and would be done with his visit. And so in my own family, people would respond to these conversations very, very differently. But again, that's sort of the premise. What your risk is, if it exceeds a certain amount, we're going to offer and talk about it. And your risk tolerance is your risk tolerance, and we'll figure out what you want to do.
When we speak of sudden cardiac arrest risk assessment, it sounds very soft. It sounds very fluffy, assessing a risk. Can we go over the elements of risk, what they are and how we determine them? So what in a family history would denote risk to the individual? Let's start there.
The way that I break it up is I really do follow the guidelines with respect to the European approach to risk assessment and the American approach to risk assessment. And so we can start with the American risk. I frequently pull up the table from the guidelines that goes through the workflow of these are risk factors we're going to think about. I usually start in the top corner there and say, look, have you died suddenly before and been brought back to life? I'm going to recommend a defibrillator. And this is probably as pushy as I get about recommending defibrillators, is that top left-hand corner. You died suddenly, you're brought back to life. We probably need a defibrillator. Sometimes I get a little chuckle out of that one in the room, Lisa, even though there's nothing funny about sudden death, because if you died suddenly, got brought back to life, you're pretty fortunate.
Yeah.
Defibrillators on the table.
Absolutely. Absolutely.
Then we move down to what you were referring to for the other risk factors, things that we know associate with higher rates of sudden death. And I say associate, meaning it's not like because you have this, you will have sudden death. They're just associations. One of them that you mentioned is family history. And family history is always, I'm very fortunate to have a lot of learners that come through our clinic because we're attached to a university. They always sort of drop their jaw when we start pushing on family history a little bit, because so many of my HCM patients, it hasn't really clicked what their family history is. What do I mean by that? I'll say, have you had anybody who died suddenly before or unexpectedly? And they'll go, oh yeah, I had a cousin with a heart attack. And Lisa, you know what happens. You follow up and you ask, tell me more. And they go, oh, he was 42. And I go, okay, did he make it to the hospital? Did he get a stent placed? Was he in the ICU? Do you remember anything about that? And inevitably, I get answers like, oh, no, he was found. I go, well, how did you know it was a heart attack? Did you get an autopsy? Did anyone do more workup? And they go, oh, no, but the EMS was pretty sure it was a heart attack. And I always kind of do a timeout there and I go, maybe your cousin's event was a heart attack. I can't tell you that that's not possible, but do you recognize it's also possible that was sudden death from HCM? So the reason I'm reviewing all of this is I think it's important for people to know their family histories and to ask follow-up questions and not necessarily just believe the apocrypha that's being passed down from above about what happened.
I'll take a minute on this one to talk about family histories versus family myths. And if you tell somebody they have a family myth, they might take that as an insult. I don't mean it as an insult, because somebody told you your aunt died of a stroke. Okay, my aunt died of a stroke. So I report my aunt died of a stroke. But what we've come to find out is the aunt that I had that died of a stroke was the sister of the grandfather who died of cardiac arrest. And likely that stroke was contributed to atrial fibrillation and HCM. So there's a high likelihood that my Aunt Alice also had HCM, but her method of death was stroke. So sudden death, stroke death, you've got to start piecing out the puzzle and figuring out what the true cause of death is. The most common person somebody will remember a cause of death from is the paramedic or the EMT, because they come in and go, oh, looks like a heart attack. Oh, looks like a stroke. And that's in your brain now. And Aunt Susie was told, oh, it looks like a heart attack. So Aunt Susie remembers it's a heart attack. There was no autopsy. So unless you're autopsy positive, cardiac arrest, stroke, you got to figure it out and share that information about your family heart health history with your chosen provider. It's critically important.
To your point, one of the things the guidelines really hit on is use of genetic counselors. And I am continually humbled how much better Matt Thomas, my genetic counselor, is at getting family histories than me. Because I think I'm pretty good at family histories, Lisa. And I spend some time, and then Matt goes in for 20 minutes, 30 minutes, and he comes out and he goes, oh, did you know the uncle didn't have an autopsy and it sounds like he was found in bed and he was only 38? And I go, no, I feel like I'm finger painting and he's doing watercolor. It's like they're so skilled at that. And so I'm really happy that the guidelines emphasized, if you can get access to a genetic counselor, please, 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 please do, because they're so skilled at helping work through the nuances. And when he finds out about the uncle, Matt's on the phone with coroners. Matt's on the phone with hospitals. He's pulling old records, right? He does things like gets me echoes of your cousin who died suddenly, who wasn't ever diagnosed with HCM. But then I look at the echo and I go, oh my gosh, that's HCM, right? So again, family history, very complicated, but I'm glad we spent some time on it because it's clearly a risk factor. The younger the person was and the nearer they are to you in the family tree, the higher the risk factor it is. But it's more complicated than that because if you have 2 or 3 second cousins, that starts to be a compelling narrative. It doesn't necessarily have to be the first degree relative.
You've survived a cardiac arrest and a family member has had a cardiac arrest, survived or otherwise. And these are 2 of the risk factors. So let's take a look at what do you think the next hot topic risk factor is?
So one really big one is a history of reduced ejection fraction. Now, ejection fraction, again, is a measure of how well your heart is squeezing, and normal for humans is 53 to 65. Most conditions in cardiology call severely reduced at 35%. That's a number that cardiologists sort of wrestle with as, oh, this is severely reduced. And it does not always register with cardiologists that in HCM, a hypercontractile state, 50 is considered a significant reduction. And so not infrequently when I'm combing through the records of a patient, I notice they've been 45, 48, 49, and no one really batted an eye because they're used to this 35 number. And then I talk to the patient and say, has your heart function ever been reduced? And they go, no. But then you pull out and you find, oh man, it has been a few times. And that's really important because when we look at the share registry data, what we find is once you reduce your function, even once, the median time to an event happening, AFib, heart failure hospitalization, sudden death, starts to be in the 5 to 8 year range. And so even if you bounce down and recover, I talk about that with patients as that might have been a little bit of a smoke signal for us. That might have been a little warning sign that we need to be really watching you carefully. We need to think about, do we need to involve advanced heart failure for things like transplant just to meet them while you're doing great, right? You don't need them right now, but I want them to know you and love you like I love you so that if things get hairy, we're ready to go in that direction. So a reduced EF at 50%, different than the rest of cardiology, another big risk factor and a frequent warning sign that you might be in that 2 to 4% of patients who progress.
And a device in those patients is necessary to get them to that transplant in many cases. If somehow they've avoided being at high risk for sudden death from every other risk factor, and then we start to head down what we call the transplant pathway, it's time to get a device in there to protect you to get you to that transplant. So when my ejection fraction reduced, I already had the ICD in place. So I was protected, but it was about 6.5 years before my transplant. So if you look at Barry wrote an article many years ago, Barry Marion wrote an article about timing to transplant or death after EF drops. And on average, it was 7 years. I made it to 6 years and 6 months. There's something about that statistic. It works. So now you've survived a cardiac arrest, a family member has had a cardiac arrest, and your ejection fraction has dropped. That's an odd one. That's not the most common. So what else would come to top of mind for risk?
While we're on function, we'll kind of deviate over to structure a little bit because there are 2 things about the shape of the heart that can be risk signals for us. One that's not very common, it's about 2% of patients, but is a big risk factor for me is an aneurysm. An aneurysm is where the heart's normally shaped kind of like a bullet and something starts to pocket out of the bullet, usually at the tip. Aneurysms are very important to identify. It's important that my sonographers are giving contrast to make sure they really see the whole ventricle, really see that whole bullet shape, because aneurysms, about 60 to 100% of patients with aneurysms get ventricular tachycardia, and ventricular tachycardia is the rhythm that causes sudden death. So aneurysms are a high risk factor. This is a little bit of a segue, but I'll mention it now because I think it's a good time, and this is a pretty savvy audience. Marin's also published on what happens to risk of dying suddenly when you get older than 60, 65. Right. And unlike other cardiac conditions where rates start to go up, In
Down.
HCM, risks of sudden death start to really go down at 60 to 65, to the point that some clinicians start taking weight off of some of these things we've mentioned, like family history. Aneurysm, however, is one where I don't care if you're 85, if you're going to be alive longer than a year and you have an aneurysm, that is a high risk feature. And I'm thinking about a defibrillator with you.
I definitely agree. Definitely agree. Aneurysms are scary because they're a little unwieldy and hard to predict their behavior. So if you don't trust them, get ready to zap them.
That's right.
Some basic logic there. Yeah. Okay. So we have our rare AFs and we have our becoming less rare aneurysms. I'm seeing more aneurysms because I think we're getting better at imaging and seeing them and quantifying them. So specifically like apical HCMs they thought they were rare. They're not rare. We just didn't see them. We're seeing them. And when you have, there's a new paper by Sherrod and Marin and a few others, where these aneurysms are coming from. How did they form? Their article suggests, and I got to go back and read it again, so if I paraphrase this wrong, my apologies, but I'll get it right, that it appears that there was obstruction at some point in that heart, and the fact that the walls were touching when that obstruction occurred over time leads to the development of the aneurysm. So again, an argument for early identification, early diagnosis, so we can relieve the pressure in the ventricle and stop aneurysms from forming. So as we talk about the need for early diagnosis, and you're going to start hearing a lot more about that from us, this is one of the things we want to get in front of before the heart's too affected.
The subtype that you're talking about is mid-cavitary obstruction. So if you could picture a tube of toothpaste, for those of you listening, if I kind of cinched down in the center of the tube of toothpaste and you pushed real hard, yeah, that's a beautiful illustration. The pressure to push that toothpaste out has to be very high. And when you do that repeatedly to the tip of the heart, this very high pressure, after time, it starts to balloon outward. Mid-cavitary obstruction, sometimes only present during exercise, is something we should be looking for because mid-cavitary obstruction, over half the time, develops aneurysm. While we're on the topic of mid-cavitary obstruction, mid-cavitary is currently not approved for cardiac myosin inhibitor. I'm sure the FDA is not listening right now, so I'll tell you I have slid a few mid-cavitaries into cardiac myosin inhibitor by saying that obstruction extended into the outflow tract, which I thought was true in those cases, Lisa, just to be fair. But I do think Acacia and Odyssey, our two cardiac myosin inhibitor non-obstructive trials, have done a very good job enrolling mid-cavitary obstruction. Those patients, anecdotally, get a just tremendous benefit from cardiac myosin inhibitor. And I'm very hopeful for that population that we're going to be able to interrupt the process to aneurysm formation.
And a couple of other people may have also used your argument. Mid-cavity obstruction is obstruction and is bad. And we want to get rid of it. While the label may not be clear on that right now, I hope that the next iteration of the label will include these important patients. Very important patients. Okay, yay. So now we've got a couple of rabbit holes taken care of. Let's talk about the size of the heart, the muscle itself. When do we start getting concerned? Is the magic number 3.0 or is it a little bit smaller than that?
Yeah. What we found is a linear relationship between thickness and risk, meaning as your thickness number gets bigger, your risk of sudden death does go up. Where we should draw the line for this amount of thickness is clearly bad enough. We need to be talking about a defibrillator. It's a little gray. I usually use the 2.6 to 3 to start introducing that concept. But when you get over 3, I start being a little bit pushier with that. And again, by pushy, I just really emphasizing this is what I would do for me. This is what I would do for a loved one. This is what my loved ones would do for themselves. Ultimately, these are your decisions, not me, because I don't have to put the defibrillator in myself. But these are the conversations I'm having. 2.6, 3, somewhere in there is where I'm starting to think about this as massive thickness with an indication for a defibrillator.
I'm looking on my other screen here because I'm bringing up some of the risk calculators and what they include and what they don't include. The first line in the sand was 3.0 or greater. And then I can remember the first poster. I was with Paolo Spirito and Barry looking at this article. And really at 2.7 the risk went up. But 3.0 was an easier number to talk about because 0.7 got confusing. I don't know. So I think a really good assessment of wall measurement everywhere, not just the septum. The free wall can be really involved and be really thick, and the septum may not be. Do you care where the wall is thick?
Yeah, it's a great question. The guidelines also did a wonderful job emphasizing the importance of cardiac MRI in these cohorts. And it's because echo ultimately is like a fan blade trying to measure a Coke can. And so you're trying to get the measurement right, but you can imagine if your fan blade's a little off, it's a little askew, the measurement of your Coke can's a little wrong. MRI is a three-dimensional assessment, and so it's much easier to accurately get the thickest segment. So there's kind of three reasons to get an MRI. One is to confirm the thickest segment. The second is to rule out mimics of HCM. And the third one, which we'll talk about in a minute, is to quantify how much scar is in the heart, because that's clearly a very prognostic feature for risk of sudden death and risk of heart failure. For your question, it does not matter where the segment is. It's just the thickest segment. Frequently, that thickest segment is actually between two different imaging planes on your echo. Frequently, the thickest segment is missed with echo, and an MRI is absolutely pivotal to make sure you're getting that right.
So we get the wall measurement, we confirm it in echo and MRI, and then we make our decisions based on wall measurement. So we've alluded to the fact that we get something else out of MRI. What is that?
Right now, this is considered to be the weakest of the recommendations in the guidelines, but the evidence is really building that this is very important. So what we do is we look at, of your total heart mass, of all of the tissue that's there, how much has scar? And we use a certain mathematical cutoff for how much scar is enough to count as part of that scar. And if your scar burden exceeds 15 is a pretty agreed upon bad number. 10 is one where people are starting to kind of flirt with, should we use 10% as the number? If you're in the 10 to 15% bucket, I'm starting to use that as another risk factor of, gosh, there's scar in your heart. We know that the abnormal rhythm actually originates from the scar and utilizes the scar to continue. This is not a good sign. And so we use that as a prognosticator to discuss risk of sudden death.
And a guy you kind of know might have done some work in this space. So can we talk a little bit about how we've learned so much about the value of scar and MRI?
There's a registry called the HCMR registry and CMR cardiac MRI, very clever name. Chris Kramer, my division chief, the former director of our HCM center now, and the future president of the American College of Cardiology, is the primary investigator, the lead investigator in this. It's about 4,000 patients that are being followed with their HCM with serial MRIs. And we're looking at how mass, configuration of thickness, how is the heart thick, not just is it thick, but how is it thick, and how much scar there is, are predicting clinical courses. And so we're learning how to use the MRI to tell you we're worried or not worried about these things in your future.
How to give a plug to Chris.
Yeah.
And all the great work that the entire HCMR team did. Okay, so we know scar is bad. We know thick hearts are bad. We know aneurysms are bad. Low EFs are bad. Family history of sudden death are bad. And previously surviving a cardiac arrest. We have 6 things that are really bad things. So let's talk about one that's a little confusing, and that's NSVT.
Yep.
So first, could you tell our listeners who don't speak in acronyms what an NSVT is?
Yeah.
And then we can talk about rates and frequency.
Yeah. So the rhythm that predominantly seems like it's causing sudden death is ventricular tachycardia. So normally a signal comes from the top chambers. There's a little pause button in the middle, and then the bottom chambers beat. And that dance, top, pause, bottom, is how coordinated beating occurs. It's actually just electrical wiring. Ventricular tachycardia is where the system gets hijacked by the bottom chambers, and the bottom 2 chambers start to beat and override this electrical circuit. And so when the bottom chambers are driving the rhythm, we call that ventricular tachycardia. We use 30 seconds as a marker of sustained versus non-sustained, But it turns out in general, when you're looking at ventricular tachycardia, the longer it occurs, the riskier it is. A good marker, and this is work that was beautifully done by the Michigan group, is about 6 to 8 beats, maybe 10 to 12 beats. That's when you've had enough beats of VT that this is clearly a warning signal. But the story doesn't stop there, because it's not just I had ventricular tachycardia that lasted. In order for the ventricular tachycardia to be unstable, to be something that we're worried is going to cause sudden death, it also has to be fast. Because you can imagine a scenario where the bottom chambers hijack the circuit, but they're beating at 100 beats per minute. 100 beats per minute is, less than carrying in your groceries from the car. Your heart usually can tolerate those kind of rates. So again, work from the Michigan group said 180 is kind of 180 beats per minute is sort of this is probably not going to be stable marker. So not all NSVT, non-sustained ventricular tachycardia, is created equal. I'm looking for 8-ish beats at about 180 beats per minute as a marker of this is another risk factor. Your heart's having warning rhythms that were they to continue, I think would be unstable. Let's talk about defibrillator.
So that number has altered throughout the years as we gained more knowledge. I believe the first iteration of the guideline was 3 or more beats, 120 beats per minute or faster. And then we went, 120 is not so bad. And then we kind of pushed the number up and maybe 3 beats is okay, but 5 or 6 beats is bad. So we're paying attention to all of it. And if you're doing 3 beat runs at 130, we're going to want to watch and make sure it doesn't start going more. So every year, a patient should be assessed for their rhythm risk, not only ventricular arrhythmia, but atrial arrhythmias. And they should be following up either with their community cardiologist or their center to make sure we're doing this annually, because it does change your risk. So NSVTs that are shorter and slower, they should have your attention and you should be monitoring, but maybe not devicing up if that is the only factor. Now let's talk about this unexplained syncope thing that's on some of the risk calculators. What are the 2 causes of fainting in HCM, the predominant causes? And let's separate the function of the heart from the electrical system. So pump function and electrical function. Take it away, Doc.
So this one's really tricky. And the reason it's really tricky without even talking about HCM is if you look at American women younger than 25, about 1 in 4 reports having passed out. I'm not talking about HCM. I'm just talking about all comers. And so passing out or reporting passing out, and I'll get into that distinction in a minute, it's really common. And so sometimes it's hard for us cardiologists to figure out, am I worried about this story or not? Are there red flag features that have, to borrow from my 5-year-old's parlance, my spidey sense tingling? Or does this sound like run-of-the-mill passing out that I'm less worried about? I use that phrase passing out or reporting passing out because many people will describe dizzy spells that kind of lower you to the floor, but you don't ever lose consciousness, as passing out. And so when I'm saying syncope, I'm not talking about I felt dizzy and sat down, I got the woozies and sat down. I'm talking about I lost consciousness. I was not responsive.
I broke my nose, I broke my wrist, I broke a bone when I went down because I went down.
As always, Lisa, you are right on top of it. Cardiac syncope occurs when your heart does not supply adequate blood flow to your brain, and your brain goes, this is bad, we should lay down. And it doesn't say we should lower ourselves to lay down. It says
now.
Out. So if you've ever watched someone have true cardiac syncope, it's pretty violent. I mean, it is like full. Typically, things that bother me are I broke an arm. I bloodied my face. I did not catch myself, right? Things that are reassuring are I've had 10 episodes of syncope, but I've never bruised anything. Well, either you are just the luckiest person and always were standing next to a daybed for each of these moments, or this is a different type of syncope that is a little bit less worrisome. So overall, the way that I would summarize this is syncope from the heart is from inadequate blood flow to the brain, causes a very traumatic fall, and usually patients suffer trauma from that fall. That's what I'm listening for to help me separate. Did you pass out giving blood and kind of just get dizzy? Or did you pass out and, break the table when you fell over and smashed your dinner plate? That's a much scarier story for me. The other thing to add for passing out is it seems as though recent passing out is a much bigger risk factor than distant passing out. I struggle with this one a little bit intellectually. If you had a really traumatic syncopal event 8 years ago, the guidelines say I should de-emphasize that I should really be worried about last 2 to 3, maybe 3 to 5 years as your risk factor. But sometimes I hear these stories and it's like, yeah, I shattered my cheek, right? I broke a bone in my face falling 7 years ago. I have a hard time de-emphasizing that as the guidelines suggest, and it really makes me to start going on a little bit of a goose chase to make sure I've adequately assessed your risk. Recent syncope, recurrent syncope, traumatic syncope, those are bad features. Distant syncope, non-recurrent, non-traumatic, those are probably more in line with that 1 in 4 young women passing out. And it's not just women who pass out. I just am giving you that statistic that's a little less scary.
Let's add in another confounder. And the confounder is they're obstructed and they've passed out.
Great point, Lisa. So there's actually, I would argue, even 2 other reasons that someone with HCM can pass out. One of them is you have rip-roaring obstruction. And again, this audience knows this, but obstruction means the blockage of blood leaving the ventricle requires the heart to generate really high pressures to make your blood pressure normal. So even though your blood pressure is 120, the heart's working at 220, 250. If you have obstruction that's getting worse with exercise, it can get so bad that the heart is unable to get enough blood flow out. And think back to what I said was the mechanism of syncope. The mechanism of syncope is the brain goes, uh-oh, no blood flow, lay down. So sometimes patients with obstruction will get exertional syncope or postprandial, you just ate, syncope. All the blood's pooling in your belly because you just ate, and now the heart's smaller and the obstruction's worse. And that's a really tough thing to separate out. I sometimes have a tough time feeling like I want to bet my mortgage. Don't worry, this was obstructive syncope, not arrhythmogenic syncope, not rhythm-associated syncope. And I struggle with that sometimes. That's a really tough one. Sometimes what I'll do, Lisa, is I'll just have a very honest conversation, and then I'll say, so we could put in a defibrillator and say, we don't know, or I can treat your obstruction and we can watch you like a hawk and see if the pre-syncope symptoms before passing out and syncope ever happens again. And if it does and you don't have obstruction, gosh, we need to treat it. And I sometimes let patients be the decider on that, but it's pretty tricky. It's pretty sticky. I did allude to something though, and that was there's another reason that patients with HCM can get syncope. For reasons we do not fully understand, about 1 in 4 patients with HCM have autonomic dysregulation. Big fancy way of saying you got your fight or flight response, you got your rest and digest response. Turns out both are kind of going at the same time. A lot of syncope, a lot of passing out is where you have all of a sudden all the fight or flight went down and all the rest and digest went off, or vice versa. You have kind of gas pedals that aren't working the right way. 1 in 4 patients with HCM have that problem. They have dysregulation of those systems. That can also make you pass out. Now, generally, that passing out has a little bit more of a warning, a little bit more of a, oh, I'm going down. Yeah, exactly.
Yeah, I've been there. I've done that. Yes.
But again,
I am that patient. I was that patient.
But Lisa, when I'm dealing with you in the office, like that's hard, right? You're looking at the same guidelines I am that say unexplained syncope. And I go, I think this sounds like a reassuring story. How do you feel? I've told you this before. If I said that to my mom, she'd go, oh, well, let's just get a defibrillator. I'll just do the defibrillator. And my sister would ask 10 million questions about the mechanism of syncope and then probably not get a defibrillator in that instance, right? So it's about personal choice and risk tolerance.
Yeah, and understanding the mechanism. And they are all such different mechanistic actions. Now, I come from a family history of sudden death. So it's multiple. So those are scary things. And before my transplant, most of my life, I would have that last type of syncope. I was no longer obstructed, so it wasn't obstruction. I wasn't having arrhythmias. I would just fall to the ground slowly because my sympathetic nervous system decided to take a break. And I just would feel like my legs were going to give out and I'd have to sit down. And it was more intense than a little short of breath, dizzy sit down. It was, you have two options. You can fall or sit. And you have about 1.5 to 2 seconds to make that choice. I assure you it's much better to sit no matter where you are. And I have sat down in some of the strangest places, train stations, the White House, the conferences, walking down the hall, like, nope, I can't do this anymore. Need to sit right now.
Yeah.
And I was just in the Orlando Conference Center and I got flashbacks of one of my little episodes. I was walking there with Barry Marin maybe 15 years ago. He has very long legs. I have short legs. I was trying to keep up and I couldn't anymore. And there's these round pillars. I'll put a picture up on Facebook. And I went to grab one of the pillars and I just, and I hit the ground. And I'm like, he's like, did your defibrillator go off? I'm like, no, this is one of those other kind of faints. And he's watching the whole thing happening. Like, well, that's interesting. I've never actually seen one before. I'm like, congratulations. I gave you a front row seat to an actual syncopal event. So yeah, we do these weird things and I'm not sure what their correlation is or why they're happening, but it is awfully weird that once I got a new heart, that doesn't happen anymore.
There's something called the vagus nerve, which is one of the biggest nerves driving the rest and digest pathway. The let's chillax pathway. It turns out that nerve goes down and then plugs into the bottom of the heart. And it actually feeds and really has spider webs all along the bottom part of the heart. What we think is happening is that the heart's going, holy cow, my blood pressure is sky high. The pressure in the heart is so high right now. And it's sending a message to the brain. And then your carotids are going, blood pressure is not sky high. Blood pressure is normal. And your brain's getting both of these signals and trying to figure out which child to listen to. And it's going on, off with these two systems. And that's what's related to the passing out. But again, 1 in 4 patients have this vasovagal
neurally mediated syncope.
And it's really difficult to manage. It seems to get better when you treat obstruction, but not always. It seems to get better when you transplant, but not always. And it's tricky. And then you start revisiting what you and I were discussing initially. When you're talking about sudden death, separating all this out, it gets grayer sometimes rather than more black and white.
And with more time and with more data, I hope that we can turn that gray into black or white based on the circumstances. So we've talked about extensive scar. We've talked about aneurysm. We've talked about depressed ejection fraction. We've talked about unexplained syncope. We've talked about NSVT, and we've talked about family history of sudden death. Now, there are 2 other factors that are in the AHA risk calculator that involve left atrial dimension and maximal gradient. So let's talk about left atria. How does your atria play with the ventricle in terms of assessing sudden death?
My suspicion in this instance is that the left atria is like kitchen smoke, not kitchen fire. Meaning the atria is a signal that something's going on in the kitchen. I don't think the atria is driving the sudden death, but I think it's like a marker things aren't going great. And the reason I think that is when pressures are high in the ventricle or when the ventricle's struggling, that pressure backs up. And the first place it backs up to is the left atria. As the left atria gets more and more pressure, what happens is it gets bigger and bigger and bigger. Similarly, there's heart muscle in the atria. And so if you have a heart muscle disease, it also impacts the atria. The more the atria is showing signs, probably the worse your heart muscle disease is. So I think of the left atria thing as a marker, not a mitigator. It's a sign that things aren't going great, but it's not necessarily causing your sudden death. Obstruction's another really interesting one. We used to think of obstruction as a very strong risk factor for sudden death. Work from Charlene Day when she was at Michigan showed this might be sort of a bedfellow of other risk factors, meaning these other risk factors are often occurring in patients with obstruction, but it's not clear that the obstruction in and of itself is the bad actor for the sudden death. And so we did these multivariate analyses that kind of showed maybe obstruction is just a bedfellow, not a driver of badness. That said, the European calculator used it in its development. And so the ACC-AHA calculator that you're referring to also uses it, because whether it's a marker or mitigator, just like the left atrium, doesn't really matter when you're trying to give a quantified assessment of risk, which, by the way, just to say explicitly, that's the difference in the two sets of guidelines. The Americans sort of embrace individuality and grayness, right? They say, look, some of these are gray, talk to your patient about them, figure out where you sit with them, and then kind of make a decision. The Europeans hate that system. They want numbers. They want, here is a number that says your risk. If your risk is above number X, offer a defibrillator. If it is below, do not. And so it's kind of two approaches to the problem based on a little bit of style and sort of cultural preference that's probably in there. And I'm making generalizations. There's people on both sides of the pond that like both calculators, but
The Americans look at LGE and the Europeans do not. The tool was created before LGE data was available. So maybe they'll update that at some point. I'm not sure. So we have these factors that can help us make decisions about risk. And then there's also the really difficult task of accepting at the moment that low risk is not no risk.
Yeah.
And somebody chimed in here as we were just opening up the session that October is the anniversary of her son's passing from a cardiac arrest. And I know this family very, very well. And it's really complicated when you have a calculator and a low risk number, but it doesn't mean no risk. So what do we do for these people who are in a space where the calculators say low, but we know there's still some risk? How do we get better? And B, how do we treat and manage and do our best to protect, but understanding that devices have complications and they hold risks too? How do we balance this? Any brilliant ideas?
Well, as a caveat to what I'll say, this is really hard. And there's no one size fits all answer. It's really difficult. It's challenging. We're all doing our best to be as precise as possible, but there's a lot of gray in here. That being said, I'll kind of introduce two concepts. The first concept is when I do the calculator for the first time, I've got my computer position. If anybody's ever had me in clinic, it's always a computer, me, you thing, and we're looking at the same stuff. And I open it up, and then I say, that's great. Your risk at 5 years was 0.7%. That's not no risk, but that's lower risk than what we would typically do a defibrillator for. And then I say, but I want you to watch something. And I'll change a factor. I'll say you passed out. I'll say a family member died suddenly. I'll change something in the calculator, and then I'll show them the number. And then I'll go back and I'll change it and I'll say, yeah, but now let's make you 20 years older. And risk typically in HCM goes down with age for sudden death. And I'll change that and the number will get better. And I'll say, what I'm trying to communicate to you is this is my risk assessment for you now, today. But I don't know what it's going to be 5 years from now. I hope it's the one that I showed you that's better, but maybe it will be, maybe it won't be. Part of the reason you're going to keep seeing me, I hope, is this moves, this changes. And if you wear your annual AFib monitor and you're having warning rhythms, boop, beep, bop, risk went up. And so this is a moving picture. The second thing I'll say is this is kind of a confusing mathematical construct, but I think it's something we can understand together. If you look at risk of your aorta dissecting, so your aorta exploding, essentially. What we know is bigger than 5.5 centimeters is a high-risk group. And when we follow that group, gosh, doing surgery on that group is better off for their long-term health than leaving the aorta that size, because that aorta is going to pop, it's going to rupture, it's going to dissect. If you look at all numbers across the country for aortic dissections, there are many more people who have rupture in the 4 to 4.5 number. And I don't care that you understand these numbers, just that that's a smaller number than the 5.5 I gave you. There's many more people in the 4 to 4.5 number that rupture than in the 5 to 5.5 group. But that's because there are many, 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 many more people that exist in the 4 to 4.5 land. And so if we apply that same kind of logic to HCM, there's more people that are going to have a 1 to 4% 5-year risk than there are people with 5% and greater risk. And so when you start looking at population data sets, what you'll see sometimes is the intermediate group is actually the group that is the most likely to pass away out of all people who passed away suddenly. And that's hard to sit and wrestle with. But at the same time, if you put in defibrillators and people who the risk of the defibrillator is higher than their risk of dying suddenly, you're not really doing them a favor. So it's really difficult to struggle with this. I know somebody who died with a lower risk because, I want to save that person. But at the same time, the way that I can save that person right now, at the moment I would have put that device in, the device was higher risk than their risk of dying suddenly. And it just gets to be a little bit of a messy soup. So I hope that's a concept that makes sense for patients. It's hard to sit with.
It is a really complicated balancing act. And it's a moving target at all times. I get to work with a lot of amazing advocates out in the world and physicians, and everybody wants to make the world a better place, right? That's what we're trying for every day, saving lives, making it better. But figuring out how to do that without causing more harm, damn, it gets complicated. It gets really, really complicated. And the best thing that we can do here at the HCMA is help educate people about the risks, give them the ammunition to have a good conversation with their chosen healthcare provider, and really dig into what's the right decision for them. And there are more people than the doctor and the patient and the family involved in this conversation. And sometimes that comes down to the payer. And you may decide, yes, my risk tolerance is here, but we've had cases where the payer's like, here's the guidelines, there's the risk, you might feel better, but it's $180K that we're paying for something that you don't need according to the records, but maybe you do to make you feel better. And crossing that line of shared decision-making with a payer who also gets to weigh in on the share, it gets really messy. And I don't believe they should be part of the conversation, but they're the one paying the bill on the policy that you signed in for. So how do we balance all of this? I hope that we get better. I hope that projects like our new HCMA patient registry help identify gaps that we couldn't see before through other data sets. There's some great data sets out there, but there's holes in them all. So over the next year to 3 years, you're going to see some changes here at HCMA and with some of our partner organizations to get better at figuring out where the holes in the data are. And one loss is a loss too many. And we don't accept one person died and, oh, well, they were rare. I got a lot of rares. I got a lot of people that I think should still be here today had we known more. But we can only take action on what we know and when we believe, based on all of the data, that we are doing good for these patients. I think I will end the sudden cardiac arrest risk assessment. Did we miss anything in that?
No, I think that was pretty comprehensive. Those were awesome.
That went deep.
Yeah.
That went deep. I'm tired. If anybody has any questions, they're welcome to put them up now, and we will have the opportunity to discuss them with Dr. Ayers. So post your questions now. There was a question about transcripts. Now, there's no transcripts that we make available, but this will be available on Facebook and YouTube and LinkedIn for, you can come back and listen to us anytime. you could just put the podcast on as you go to sleep and we'll be right there with you. You probably don't want to listen to this thing going to sleep. It's a little anxiety provoking conversation about sudden death that's really going to put you to sleep. No, listen to us during the day. We don't have a transcript, but you can rewatch it at any time. So you can post your questions now, but I wanted to get outside of sudden death and take a few minutes to talk about the rest of your heart health. We focus a lot on structure, anatomy, sudden death risk, stroke risk. How's our mitral valve doing? What's the ventricle doing? But what about coronary artery disease? What about somebody having to need something like a PCSK9 inhibitor for controlling cholesterol? And what about the rest of our heart? What should we be doing? How do we keep it all healthy?
The fact of the matter is most patients with HCM are going to ultimately have something happen to them like run-of-the-mill heart disease, run-of-the-mill strokes, run-of-the-mill cancer, more likely than they are to have something from their HCM. So it's really important to address these other things. That said, a lot of primary care doctors are a little bit nervous about changing meds for their HCM patient. They're nervous. How did this interact? I don't want to mess with the HCM stuff because they think of it as rare disease, even though it's not that rare. They don't want to muddy the waters. And then when you're seeing your HCM specialist, they're often very hyperfixated on the HCM stuff, right? We just spent an hour talking about sudden death risk assessment. These are very, very complex topics.
Yeah.
One of the hardest things for me to do as a cardiologist is actually to make sure I purposefully gear shift and say, how's your blood sugar? How's your blood pressure? How's your cholesterol? Are you exercising? Did you get your cancer screenings? It's breast cancer awareness month. Did you get your mammogram, right? To think about all of these other things, it's almost like I have to step out of my brain and go back into general cardiology land to make sure I'm addressing. So what I would encourage people listening to this to do is advocate for yourself, encourage your cardiologist to make sure he or she is doing that same intellectual frame shifting, is going, how is your blood pressure, right? Or you can ask them, by the way, how's my blood sugar? How's my cholesterol? How's my blood pressure? How's all the things that all the other Americans get to confront, right? Not just heart health. And I would add to that, Lisa, something that you and I know feel very strongly about. Mood has an incredible impact on all of this.
Yep.
So if I treat your obstruction and you're still clinically depressed, you're not going to feel any better, right? Mm-hmm. And I don't like walk around patting myself on the back saying, guess what? I made you live longer, but you feel terrible. I want both things to be better. And so again, you've got to, as a patient, I encourage you to think about self-advocacy. Hey, doc, is there anything I can do for my mood? Hey, doc, is there anything I can do for my blood pressure? Because it's hard for me, I'm confessing to you, and I'm sure it's hard for others to make sure you're doing that frame shifting and not just treating HCM.
Excellent points. If you have diabetes, if you have high blood pressure, if you are depressed, if you aren't sleeping, if you aren't doing some basic exercise to keep your body moving, all of these things will impact your heart, will impact your HCM eventually. But if we keep them in check, they don't have to. Hell, I found out after my transplant, I went to ESC last year and I did one of those little blood tests for lipoprotein A. Well, I learned something new about myself. The look on their face, they're like, ooh, wow. I'm like, did I win an award? They're like, yeah, maybe for the highest rate we've ever seen. So I am now on Repatha.
Yeah.
Because I was not processing, I lacked the ability to process cholesterol effectively. And I was having a problem, and that could have led to CAV post-transplant.
Yeah.
So I had to change everything up and go on, triple level statins and a PCSK9. So you don't know what you don't know until you look. And frankly, there wasn't a test for that before. Right. So I would always get yelled at for having high cholesterol. I'm like, I eat like a queen. It's not me. Like this is not my thing. I need another injection. So, okay, we'll do that. So we do have a question, like a comment, but I'm going to turn it into a question. Going back to sudden cardiac arrest risks, what role does the genetic variant present in a particular individual hold for sudden cardiac arrest risk. I'm going to ask it in two stages. Like, what do the calculators that are available now say, which I believe they're absent here, and what do we think about a particular mutation and risk?
You have the smartest listeners. They always ask the best questions. There's conflicting data about how to think about genotype, whether or not you have a genetic mutation, and your risk. Marin's group recently published a paper suggesting really outcomes looked very similar between genotype positive and genotype negative patients. And it was a very good paper. It was well done. And that's what the paper suggested. The SHARE registry has data that suggests something different, which is that people who have an established genotype, a known genetic mutation, do slightly worse than people who have a variant of uncertain significance, a mutation where we go, that's funny, but I'm not ready to say that's bad. It just, I don't know what to do with that.
They look a little funny.
Right. And that does a little bit worse than people who have no mutation at all. So I think there's more to come on this. My suspicion had been that genotype positive patients likely have slightly more events, but that data is somewhat mixed now. There used to be a very strong belief that certain thin filament mutations like actin mutations were more likely to cause sudden cardiac death. They were more arrhythmogenic, causing bad heart rhythms. That data is also not panned out. So there is work to be done in matching your genotype, your genetic makeup, to your phenotype, your physical shape, and ultimately your outcome. There's more to come. When patients ask, I tell them what I just told you. I suspect it might be a risk factor. More to come. Don't know.
More to come. Okay. That leads us through a full hour, believe it or not. That was a great deep dive. It did. It flew by really fast, but there was some really great content there. So thank you for that. I do have a couple of announcements. It is October, people. We got back to October, and that means it is HCMA annual patient meeting time. And you too can sign up on our website. The link is below. And we will be in Boston this year, October 27th. We will be at the tail end of the HCM Summit. The event will start at approximately 1:30 in the afternoon on Sunday, and we will wrap with a dinner that starts at 7 p.m. So we should be all wrapped up by 9. It is a little bit of an abbreviated schedule this year. It is a half-day, three-quarter day session, really. We're going to go about 7 hours. We have some great speakers. Some people that are here with me today are going to be on faculty. So we've got some amazing physicians ready to speak with you. I do encourage you to get there a little bit early. The HCM International Summit 8 will be concluding, and all the patients are going to be permitted into the overflow room to listen to the last day of the International Summit, as there were some policy changes that made the summit not available to patients as participants this year. We're working on that. There's been some policy changes in Europe that I think are to blame for that policy shift. It's not the people who ran the meeting, trust me. We will hopefully see you all in October up in Boston. We will also be announcing shortly that we will be doing a larger than normal meet and greet, but not a full meeting, in San Francisco the first weekend in December. So stay tuned for that announcement to come out. Lots of great news coming out of the HSFA conference, which we're going to be talking about at the end of October. Our patient registry is going to IRB hopefully next week for review. And we have another big announcement, and that is on Monday, the HCMA team will be growing again with the hire of our 10th and 11th full-time staff members. So we are really excited to bring in 2 amazing women, Maria and Artie, who will be doing intake and consenting. So you're going to hear some new voices and meet some new people. We're super excited to have our organization grow to serve this community better. Stay tuned for some really exciting advances and opportunities to participate in focus groups and roundtables, fundraising committees as well. So if you're interested in volunteering, please go to the website and sign up as a volunteer today. We need your voices at the table to bring about the change that we know we need in this community and to help provide services to you, your families, and the undiagnosed that yet to be found. So on that, I wish you all a very meaningful Sudden Cardiac Arrest Awareness Month. I will take a moment in closing to remember all of those we've lost along the way, as they may be gone from the physical, but they still stay with us in our hearts every day. For those of you who are grieving and find this month difficult, please remember the HCMA provides online discussion groups, including our emotional wellness group, that maybe you'll need to be with some of your big-hearted friends this month. So we thank you for being part of this amazing community, and we look forward to continuing to serve you in the best possible way. Dr. Ayers, thank you so much for your time. I know you took a little bit of a mini vacay with your family, and you're not in the office today, and that just speaks to the wonderful human that you are to give your time, even when you don't have to your patients. Thank you. Bye, everybody. We'll see you in Boston later this month.
The Hypertrophic Cardiomyopathy Association thanks the following sponsors for today's podcast: Cytokinetics, Bristol Myers Squibb, BioMarin, Tenaya Therapeutics, Viz AI, and Alnylam.